Here today we're talking from the demand and capacity optimization tool about unseen data and if we can use it to control patient demand. I'm joined by colleague Steve. I'll give you a bit more of an introduction to Steve in a moment. My name is Max Pardo-Roques. I work for an organisation called Develop Consulting. We are a consultancy firm working in the NHS and with general practice for more than 10 years, 12 years for myself. And we are national delivery partners for NHS England's General Practice Improvement Programme, which means that over the last 5 years, we've worked with somewhere between 1,500 and maybe 1,700 practices across the country, all the way from your largest practices, of which Steve's a representation, all the way down to some of your smallest, right the way from the north, right the way to the south. That programme is designed to provide fast practical improvement for general practice, but we try to use data where we can to identify some of those opportunities for improvement and then help you to implement them in practice. While we've been doing that, we found that there were a number of issues in some of the data that existed in practice, and we therefore decided that there was something that needed to be done. So when we were trying to base those improvements on the work that we were doing, we found that actually often the data was unreliable, and I'm going to come on to a bit more detail about that in a moment. I'm joined today by my colleague Steve New. Steve works for an organisation called Solihull Healthcare Partnership, and he's going to give you a bit more detail about himself in a moment as well. So the data challenge for practices, as I've already referenced, we've collected data, or we worked with you as practices to collect data from your clinical systems, from your telephony data. Typically now practices have got a very good amount of information, particularly if you're on cloud-based telephony systems, data points that you can pull from. However, that data is not always super reliable for practices to make decisions based on, particularly if you're talking about clinical system data, where there's often issues around reliability, coding issues, challenges around that space. But it's also quite challenging because clinical system data and also your telephony data really only captures what has happened in your practice and is therefore quite reactive, rather than being proactive and saying what could or should have happened. And so what we tried to do with the program or the product that we're going to talk about in a moment, and Steve's understanding and his experience of it, we tried to build something that looked at those blind spots in your clinical system data and gave you an opportunity to think about what can't we see, and if we could see that data and visualize it and understand it better, what opportunities might exist from that, and then how do we go about making some of the benefits from it. So we developed a program or a tool called the Demand and Capacity Optimisation tool, which does exactly as it says on the tin, thinks about the demand and the capacity your practices are facing and have. And to do that, we decided to collect data around the things that specifically your clinical systems, your telephony systems aren't. So we do that using a tool. We collect data on every patient interaction over the course of a week, and that means that every patient interaction, when a patient walks in the front door, speaks to a receptionist, we'll collect some data on that. If they ring up and speak to a care navigator, we'll collect data on that. If your clinician is face-to-face with a patient, we'll collect data on that, regardless of what clinician that might be. And over the course of the week, we'll collect thousands of data points with your practice to understand exactly how your practice is working and the demand that's being faced by it. Not only that, we'll think about what did happen for those patients, but what could or should have happened. The data then gets provided into, gets analysed using our tool, and it develops a pack that looks like this. The pack is fairly large, and it gives you some information about how your practice is currently operating, where some opportunities for improvement exist, and then how you might go about making those opportunities for improvement. I've kept my piece there fairly short because I want to be able to give Steve the time to talk about his experience and how the tool, the Demand and Capacity Optimisation tool, operated in his practice and the outputs they're able to find from that. So I'm going to hand over to Steve.
My name's Steve New. I'm here from Solihull Healthcare Partnership, SHP. SHP is a GP practice in Solihull in the West Midlands that was formed in 2019 through the merger of 4 partnerships, with the vision of creating a single practice primary care network serving over 50,000 patients, delivering services at scale from our 7 GP practices. So if I look back, realising our vision has been hugely challenging. Our 4 merged partnerships had at least 4 different operating practices, different ways of working, different working models, a workforce that identified itself as single site practice level rather than the new PCN level. Large number of very vocal patients who didn't really believe that bigger was better. And throughout 2021 and 2022, we had high levels of patient complaints about access, long wait times on the telephone for patients to get through and be answered, low levels of patient satisfaction, high levels of staff sickness and high staff turnover. But we still had the belief that delivering services appropriately at scale, at PCN level, across our 7 sites was the right vision. We welcomed the support through the PGP Quick Start programme initially, through NHS England's primary care transformation team. We were introduced to Develop Consulting, Max and the team, who provided management consultancy up to and including last year's intensive support programme. And it's helped us get to a much better position that we're in now, where we're now a PCN with a good reputation, an engaged and motivated workforce, and importantly, a generally happier group of registered patients with a very much growing list size. One of the big projects that we did undertake early in our merger was to achieve the transformation of our traditional receptionist model into a model where we had the role of care navigator who consistently signpost all patients to the right place based on clinical need rather than delivering a first come first served service. We went into consultation with our then 51 reception staff. We made the role redundant. We re-employed the workforce as care navigators, and the disruption unsettled many. It led to some staff turnover, but we had to create a new operating model across the whole of our organisation that would help manage very high patient demand with a finite clinical resource. So when I reflect back on the last few years, one of the most important support projects has been the demand and capacity audits. We tried a few different audits, and the best one that we've used has been the demand and capacity optimisation tool that Max has just introduced. We carried out an audit over a 1-week period and assessed well over 3,000 patient contacts. The aim was to improve access for our patient population by seeking real input from our care navigator team, our doctors, our nurses, including AMPs, our ARRS team, including our clinical pharmacists, our social prescribers, physicians associates. And at the end of the week, when the audit was complete, as Max said, we received our data pack. This one's ours. And this is a very comprehensive report that captures the feedback from multiple staff groups from thousands of real patient interactions. It told us an awful lot, but I want to focus on 2 particular areas. And these were 2 areas that have helped us prioritise our operational improvement efforts, which have been based on high quality data rather than on anecdotal opinion. The first one. We found that a large proportion of our patient encounters were not resolved in the first instance. Now, this suggested that in many cases we were failing to achieve our aim of delivering our model of right access first time. We also had a significant degree of variation. You can see it on this slide, huge variation between staff that were in similar roles based on similar type of encounters. And so we had very different in patient encounter completion rates for our patient contacts. So what do we do about it? What we've done is we've reviewed and developed a new induction process for our care navigators. We've developed a comprehensive care navigator training program within SHP, which includes skills and knowledge assessments, certification, a reward and renewal element for achievement of our new SHP Care Navigator skills and competency framework. We've introduced this by adding a number of new Care Navigator team leaders to deliver this training program. For the insights that the PAT gave us from a clinical perspective, the one I want to highlight is the data reported that in around a third, 33% of all consultations, the pre-consultation information was inadequate. Now we calculated that resolving this could provide back the equivalent in time of more than 1,500 10-minute consultations per year, as well as improve the consultations for our clinicians. So what do we do about this? What we're doing is we're changing the way that we capture patient requests for clinical appointments. We evaluated the tools available, and after quite a thorough options appraisal, we've settled on the implementation of the eConsult tool for SHP. We've developed a phase implementation of eConsult, and 3 months ago, in November last year, we launched phase 1 of the SHP eConsult rollout. And over the next 2 months, we plan to use eConsult to capture the patient's reason for requesting all acute same-day appointments. However, the patient chooses to access our services, whether that be by telephone, in person, by presenting at the reception desk at any of our 7 surgery sites, or of course digitally. The third phase of our eConsult is over the next 12 months, we're working with University Hospital Birmingham, our secondary care provider, to look at how we can integrate with the planned e-triage tools that University Hospital Birmingham are putting into their accident emergency department, the urgent primary care centres that are opening, and looking at how we can appropriately transfer information on acute care between patients who present at the GP practice and those that present at the urgent care centre and the emergency departments. Now, through our 1-week audit, we found lots that we didn't know. Some of the points, the highlights are listed on there. 27% of Care Navigator encounters, the Care Navigator reported that they were not able to book with the right clinician. In 37% of all consultations categorised by the clinician felt that the patient demands were likely to increase. And as it says, 16% of consults were partially a result of our practice failure demand. So we've reviewed the elements of practice failure demand to see what areas that we need to improve operationally to eliminate this. So there's lots that we can do and improve, and this data has helped us prioritise our improvement projects at SHP. So the question, did the demand and capacity optimisation tool help us control patient demand? What it has done is it's really helped us deal with demand in a more appropriate way and optimise our capacity, where we're trying to deploy front of house care navigation across all patient encounters.
Yeah,
I'll hand back to Max.
Thanks, Steve. A couple of bits there as well, just to add on to Steve's point. If we think back to some of these slides here around the consultation there, the data that was existing for clinicians, and the pre-consultation quality of information, These things are day-to-day challenges that your clinicians find. Obviously, when your clinicians are in the consultation rooms, they might be anecdotally saying, this stuff's bad, or we have an issue in this place. It's very hard to then quantify what that actually looks like and do something about it. And information like this gives a really strong indication of what you might want to change and why you might want to change it. But it also drives a bit of change of behaviour in your practice, because when people can see the effect that their work is having down the line, so pre-consultation information in this instance, they understand why you're asking to change it, and therefore the ease of making change in your practice and also the sustainability of those changes is greatly improved. And that's really important when we think about how we go about making changes for practices, for clinicians. And a lot of this stuff is just not seen on a day-to-day basis. I'm sure everybody has clinicians, so maybe clinicians in the audience. I'm sure there's lots of gripes everybody has with how their practice operates. If we can put some data to it, we can start to think about how we change that.
Biggest thing was around our care navigation was the variation, the variation in the outcomes from the interactions that our team had with the patients. Our care navigation takes place across our 7 surgery sites. It would be nice if we got the opportunity to change the estate. The estate is just not really, it wasn't designed for the model that we're operating now. So we have to manage our team and service delivery across all 7 sites, and that was that's a very difficult challenge. What we didn't realise was the difference in the way that we deal with our patients across all of the sites. We had a vision from the start of creating a consistent model across all sites, so it was one SHP way, but we still had very different working practices across all surgeries. What this gave us was that information that we suspected, but we didn't know the extent of it. And what we found was the extent of the variation was huge. And that led us to, over the last 6 months, develop a really significant program of Care Navigator training. And the Care Navigator training, the thing that led, the point that we didn't really appreciate was how much work was going to be involved in training all of our staff. One of the biggest areas that we found we'd overlooked subsequently was that we flex up our telephone answering to deal with the 8 a.m. rush. So we've got a number of staff who may be secretaries mostly, or in office administration mostly, rather than front of house, a traditional receptionist, which we now have Care Navigator. But without giving the same level of training and skills and knowledge and competency to the staff members who are very, very part-time, probably only for the first hour of the day in the morning, it was undoing everything we'd done, because all that staff group could deliver was a first-come, first-served service. So now what it again uncovered when we look back is that the training for those staff who particularly answer the telephone on a very part-time basis is as important to make sure that they've got just as much training as somebody that does it full-time, 37.5 hours.
And I think the bit for us that we like to hear about that is the impact of that is going to be quite significant, not only for you as a practice and then the day-to-day lives of your team. And like you said before, you had quite a lot of staff sickness because of the challenges around that, but also it really improves lives of the patients and the care you're able to provide.
Hugely. We were experiencing huge numbers of patient complaints. I was getting hauled before our local MP, our local council, the council health and wellbeing scrutiny board, to find out where we were failing. But what we needed to do was to make sure that we could change that, we could transform our operating model, but that's took probably the last 18 months in particular, and we're completely indebted to the support from Develop Consulting. having management consultants support us and helped us, we armed our arms when we were offered support from NHS England's primary care transformation team. The very significant area has been the practice improvement project, the intensive support package for the 6 months, which went up until November last year, has helped us to understand and then develop a plan, and which we now utilise as our continuous improvement programme. We conducted a complete review of our terms and conditions, particularly pay. Traditionally, our receptionists have been the lowest paid in the surgery. That's not the case anymore, they're now the higher. We changed the hourly rates. We've also, with our training programme, put together a reward and recognition scheme where moving through 4 tiers of training competency through our skills and knowledge framework, the care navigator will move from tier 1, 2, 3 and 4, which we've developed, again with support of Develop Consulting. We believe that our care navigators have to be the elite of our administrative staff, our non-clinical team, and without that we can't move away from our first come first served model in the morning. But yeah, it's been hugely challenging. We had to, of course, create a business case to present to the partners, because this has changed our workforce cost model. It meant that some of the staff, it was quite disruptive. It meant that some of the staff who traditionally were our receptionists didn't really have an appetite for the new way of working, but that didn't mean it was wrong. I'll answer that one. The most significant impact that it's had on our clinical staff is that in terms of our practice reputation, if we went back 2 years, 2.5 years, our reputation was on the floor. We were struggling to retain staff. We had a high turnover of both clinical staff and non-clinical. That's completely changed. We now have full complement of GPs. When we're recruiting, we recruit well into those positions. We now only use locum doctors to cover sickness, long-term sickness, and that, in terms of feedback from the GPs and clinical staff, that's been the biggest area of input. Well, what we've seen is we've seen a shift in our finances. When you look at the accounts and the workforce costs, there's been a shift, but particularly from other areas of the administrative team. We have had to we've had to accept higher cost in terms of care navigation, but it's not significant. It's not a big increase. That the biggest group who've been affected have been our secretaries. Our secretaries, the medical secretaries within the practice, have historically been those at the very top. They're not anymore. The role has changed, and they're now much so. So there's been other areas of saving, and that's been a big one.
Just Steve, to add to that, I think one of the things that we often find from practices before we work with them is they know they've got problems, and they don't know where, and they don't really know how to find them. And that's one of the things that this does really nicely, is it does give you a clear roadmap about what changes you can make. And in Steve's practice, he's talked a lot about care navigation, but in another practice it might be something completely different. Yeah. And that's the nice thing, really. It will target those issues that are right for you.
In terms of communication, we felt across on this whole journey was really, really important. So one of the new roles that we did employ was a communications manager for our organisation. It's a significant GP practice. We've now got over 200 staff. We started with 54,000 registered patients. We're now at 56,500. But we have a communications manager who carries out both the internal and external communications. In terms of how we presented this to the workforce, we presented it extensively. We have monthly full staff meetings. At one of the meetings 3 months ago, I stood at the front with a full printout of our competency matrix, big screen that really demonstrated that when you move from tier 1 to tier 2, moving from essential care navigator skills to advanced care navigator skills, the screen was showing that your pay also moves from there to there. What we've had to do is we've had to make sure that we had very robust processes of assessment. What is the nice thing that's happened since is that many of our other teams, I talked about our secretarial team has now said, they come with a proposal to say, for our team, we want a similar structure. We want to have that model of moving from this level of knowledge and skills to this, and have that same kind of tier 1, tier 2. We've got the same within our workflow team. We've got a dedicated team that deals with clinical correspondence management. So that's been the next one, where this is very transferable amongst other teams within the organisation.